The TMJ-TMD conundrum is real and has been puzzling the dental and medical professions for decades. This is the TMJ-TMD Demystified podcast with Dr. Tony Urbanic, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ-TMD Demystified podcast.
Hello, TMD warriors. Welcome to beautiful Brentwood, Tennessee. I'm Tony Urbanic, and this is TMD Demystified. We are gathered here for the next episode of this podcast, which is entitled TMD-TMJ is actually an orthopedic disease. As I've spoken on before, I parallel a weekly blog that I write and the weekly episode on TMD Demystified. I parallel the topics, sometimes with the exact title. And this week's blog was entitled TMD-TMJ is actually an orthopedic disease. Please let me explain. It goes back historically. I've spoken on this before, but it really is important, I think, for anyone who treats TMJ disease to have a historical viewpoint on many aspects. Number one, why TMJ was given to the dental doctors to treat, which is not where it actually began. Historically, it is important to understand, who else had looked at this syndrome or disease and tried to make heads or tails of it. But eventually it got placed in the hands of us dentists. And I think historically it's important, it's critical to understand how that came to be. The early investigators on this problem were certainly very smart men. They had limited experience with the patients with the symptoms, as unlike we do now, and we know how large a group of patients this applies to, like millions and millions of people, primarily women. And back then, it was overlooked so often because it was so easily misdiagnosed, misconstrued as other problems, having anything and everything to do with things that weren't connected to the temporomandibular joint. And I can easily see, looking at the history of this, how it was overlooked for so long. And then finally, the insight got deep enough where it was considered, well, these disparate symptoms may be coming from one place. And what's that one place? Well, the temporomandibular joint. So it all started out with a paper which actually was delivered to the Texas Ophthalmological and Otolaryngological Society in Dallas, Texas, on December the 8th, 1933. And that paper was delivered verbally by Dr. James B. Costin, MD. And he later wrote this paper up, which was published as the original article in the Journal of Otolaryngology, volume 43, March 1934, pages 1 to 15. This article actually is fairly hard to come by. This is the original article by Dr. Costin. And in it, he reviews 11 patients, 11 separate patients, and goes into significant detail on the anatomy associated with the temporomandibular joint and relative and associated structures. And apparently this information kind of set fallow for a while, but it was considered Costin syndrome, and nothing much came of it as far as the dental profession was associated or part of, until 1947, when Dr. L.G. Perry, P-A-R-R-Y, DDS, from East Point, Georgia, published an article in the Journal of the American Dental Association, 1947, December 1st, volume 35, pages 831 to 833. In that article, he reviews two patients with what he termed Costin syndrome and theorized that the cause of Costin syndrome was overclosure of the bite, deep bites, and lack of posterior teeth. It's a very brief article, but this is a very seminal article that actually was the kickoff, if you will, for the dental profession, focusing on occlusion as the primary problem causing the disparate symptoms of TMD, TMJ. And he has, in this very brief article, his conclusions, which I can make this article available to anyone who contacts me. But his fifth conclusion, I will read, and that it is construction of dentures to restore molar support, full vertical dimension, and balanced occlusion may correct the disturbance. Emphasis on may. For patients who have their teeth, occlusal splints are indicated. That was the last sentence of his conclusions. Repeat for emphasis. For patients who have their teeth, occlusal splints are indicated, but he never defined what an occlusal splint was. But again, in 1947, the year I was born, Dr. L.G. Perry kicked this off by making the consideration theory that occlusal splints are indicated for people who actually have teeth, although the theory at the time was the problem was overclosure and lack of posterior teeth. And then, as I've spoken on before, his paper sat fallow for quite a few years until the mid-60s and early 70s, when there was quite a bit of work done by the oral and maxillofacial surgeons trying to develop a surgical correction for temporomandibular joint problems. But prior to that, occlusal splints, which basically were night guards, were considered treatment of choice. And that was a treatment of choice. When I was in dental school, a night guard was a treatment of choice. And to this very day, 50% of the dentists prescribe for the patient a night guard, upper or lower or both, and give it to the patient as treatment for their temporomandibular joint problems. Amazingly, I have to emphasize, amazingly, as far as I can tell, historically, coming from the last conclusion on a paper in 1947 by Dr. L.G. Perry, for patients who have their teeth, occlusal splints are indicated, but never defined what a splint was. Well, we've been off and running for many years, and we now know through basic study in anatomy, cell biology, that the one general cause of all the symptoms is inflammation within the temporomandibular joint. Inflammation creates the symptoms. Inflammation in the joint, one way or another, creates all of the symptoms of frequent or recurring headache, earache, jaw pain, neck pain, tinnitus, subjective hearing loss, vertigo, upper back and shoulder pain, arm, hand, finger tingling and numbness, and various kinds of locking. All the direct result of inflammation. If the inflammation was not within the temporomandibular joint, none of those symptoms would occur. That has been proven. That is fact. It knocks the pegs, the knees off of the myofascial theory, because the common denominator is inflammation. There's a lot to be written. There is a lot written on the two types of temporomandibular joint problems, which there are two types. There's what is considered theoretically the myogenous temporomandibular joint problems coming from the muscles. And I want to make this really clear. I want to really make this distinction because this is really important. It's in the literature all over the place. The two types of temporomandibular joint problems are myogenous and arthrogenous. Arthrogenous from the joint itself and myogenous from the muscles. And that is in itself is a total confusion, because all temporomandibular joint disease stems from the joint itself. So it is arthrogenous. And the myogenous is an effect of the arthrogenous disease. So the disease is an arthrogenous disease from the joint itself. And the inflammation within the joint creates the muscle spasms, which gives the appearance of myogenous. That is, the disease is created within the muscles. This disease is not created within the muscles of the mastication or the muscles of the neck or the muscles of the upper shoulder girdle or the strap muscles in the side of the neck. That is not where this disease originates. It doesn't originate from the muscles. The muscles are the effect of the signals from the brainstem that says tighten up. When the brainstem gets the signal that there is inflammation within the temporomandibular joint. I cannot say this any clearer in my mind. It cannot be any clearer, but yet textbooks are continuously repeating this misinformation that it just isn't true. For sure, the muscles get tight. For sure, when muscles get tight, they pull on the periosteum and stimulate the nociceptors within the periosteum, and it hurts. But the disease itself is not because of overuse of a muscle. It is due to trismus of the muscle trying to get tight by getting autonomic signal from the brainstem, tighten up. So there is no such thing as the myogenous type or cause of TMD. The myogenous is an effect of the arthrogenous cause. And the only three causes of inflammation within the temporomandibular joint are bruxism, acute trauma of various kinds, and functional malocclusions of various kinds. I've discussed that thoroughly before, but I want to make this really clear and take it all the way back to the history so that doctors who study this and doctors who treat patients with this problem get a broader viewpoint of how all this occurred. If you understand how all this occurred, you kind of feel better about taking responsibility on its treatment. Whether or not you take the responsibility as a doctor to refer it on to a doctor who treats it, or whether you take the responsibility to learn the very simple aspects and concepts of treating it yourself. But again, that's why I bring out the history here. How did all this originate, and all this nonsense that is now used to treat temporomandibular joint problems, that I have used the term smoke and mirrors, and I use it intensely, and I use it because that's the consideration that it is. It's smoke and mirrors when you inject the muscles of mastication with Botox. Yes, you will paralyze those muscles. Hopefully you will not get complications of affecting the facial nerve, which is a complication of using Botox. But it does not address the cause, which is inflammation within the temporomandibular joint. So getting back to the title of the article, let's circle back now after the discussion of the mechanism of temporomandibular joint problems and the historical beginning of temporomandibular joint diagnosis, starting with Dr. James B. Costin. Let's circle back to my comment. The title of TMD, TMJ is actually an orthopedic disease, because the orthopedic doctors who didn't communicate with the dental doctors knew all about what they called joint splinting. If the orthopedic doctors had taken control of the temporomandibular joint, or kept the control of treating the temporomandibular joint, and not allowed, if you will, I'm not sure it was an allowance, but the orthopedic doctors certainly have control of all the other joints of the body, treating the body. They are the specialists of joint pathology. And if they had kept control of addressing and treating the joint pathology of the temporomandibular joint like they treat the joint pathology of all the other joints in the body, this problem would have never gotten to the point where it was a series of misconsiderations, misunderstandings, and smoke and mirrors trying to treat a problem that was actually pretty simple. Tennis elbow is a problem well established and well understood by my orthopedic colleagues, and they know about joint splinting, where inflammation of the lateral epicondyle of the humerus gets inflamed by too much motion, repetitive motion of the forearm, sending an autonomic signal to the brainstem, which announces that the lateral epicondyle is inflamed. And the brainstem gets that information, modulates it, and sends a signal back down through the autonomic system, sympathetic portion, to the muscles, instructing them to tighten up, don't move the joint. And the orthopedic doctors call that phenomenon joint splinting, to splint the joint. It just so happens that every joint in the body operates with that same phenomenon. Elbows, knees, hips. And if the same phenomenon occurs in all the joints in the body, then it stands to reason that that phenomenon occurs in the temporomandibular joint, and that when the brain stem gets the signal that there's inflammation within the joint, whether it be the initial inflammation or the inflammation which now has occurred untreated or unsuccessfully treated for 5 years, 10 years, 20 years, 30 years, 40 years, and constantly sends out signals in desperation to the various muscles of muscles of mastication, muscles of the neck, tighten up the jaw, then tighten up the whole head, then tighten up the upper shoulder girdle, which explains easily in a level of understanding, anatomically, physiologically, cell biology-wise, what is going on with TMD. So tennis elbow and TMD are the same disease. And the orthopedic doctors knew about this joint splinting, as far as I know, since I was trained at Vanderbilt and got this information in my orthopedic rotation in the early 70s. And that is why TMD, TMJ is actually an orthopedic disease. Now, at this point in time, the chances of the orthopedic doctors taking control of treating the TMD are less than slim to none. I would say zero. And the potential of the ENT doctors of treating TMD actually is less than zero, because treating temporomandibular joint disease with an appropriate oral device, if you will, an orthotic, that decreases the loads on the temporomandibular joint, like a set of crutches would take the load off a knee, which allows the inflammation to decrease. And when the inflammation decreases, the signals cease coming out of the brain stem that says tighten up. And when the muscles cease getting the signals to tighten up, then the stimulation of the nociceptor stops, and therefore the headaches stop and the jaw pain stops. The neck pain stop. The upper back pain and shoulder girdle gets loose again, and all these symptoms diminish. It's also interesting to read on this initial article by Dr. Costin that he has some diagrams, anatomical diagrams, in the initial article. I was fascinated by this. I certainly want to get this out. Let me just show it to you. Again, I can send you a reprint or a copy of this, but this is just a copy of the temporal bone. But on 1934 initial article, he has the petrotympanic fissure. The petrotympanic fissure is obviously shown to be in place. And the petrotympanic fissure is very important because the petrotympanic fissure, which is only roughly 2 millimeters in length from the glenoid fossa into the middle ear, which allows inflammatory fluid to get from the middle ear, inflammatory fluid to get from the glenoid fossa into the middle ear, creating tinnitus, subjective hearing loss, and vertigo. When the inflammatory fluids and the effect of the inflammatory fluids circulate within the middle ear, in the hearing mechanism and the vestibular mechanism. So all of the symptoms that I reeled off, headache, earache, jaw pain, neck pain, tinnitus, subjective hearing loss, vertigo, upper back and shoulder pain, arm, hand, finger tingling, and numbness are associated with inflammation, and when the inflammation decreases. And then finally, the joint itself, the dislocation of the disc is not muscles pulling on the disc. That is, again, an effect of inflammation within the joint itself, which causes the synovial fluid to significantly decrease its lubricating ability, like to zero, and it becomes sticky. Inflamed synovial fluid becomes sticky like glue. And so as the motion of the condyle moves over the meniscus and actually translate, as it gets sticky, it pulls the meniscus out of position. The meniscus is not pulled by the muscles. The inflammatory fluid creates the synovial fluid to get sticky rather than lubricating. And therefore, in the translation portion of the condyle, it pulls, because it's sticky, pulls the meniscus forward. And when that happens enough, it will pull it far enough to keep a permanent dislocation out in front. Or, the initial ones, the inflammation goes on, is the click. It just, it clicks back and forth. It's a little sticky, so it'll click, click, click until finally it's fully dislocated, either temporarily or permanently. Again, the effect of inflammation within the joint. And when the inflammation subsides, then the synovial fluid goes back to a more normal ability to lubricate the joint. And although now the meniscus is loose, and it's always going to be loose. Once it's loose and those ligaments are stretched, it's going to be loose, and you're still going to have clicking, but you're not going to have the dislocation permanently. And that is a fascinating thing that actually I was able to observe in hundreds and hundreds of cases, and that is the locking of a dislocated disc. On MRI, the dislocation, whether it comes back 100%, but I can tell you symptomatically, after hundreds of cases of observation, symptomatically, that disc is no longer permanently dislocated and is not permanently an obstruction to the condyle coming down and translating, and therefore interincisal distance gets back to normal. All this could have been avoided for decades if someone had listened to our orthopedic colleagues and understood that this joint is just like any other joint in the body. It is not different as we are taught in dental school. It is not unique as we are taught in dental school. We are taught in dental school it has a unique name, gangliomo-arthrodial joint. And on that basis alone, they concluded that this is really a difficult joint because it had a difficult name. And it is not a difficult joint. It operates like any other joint in the body. That is the take-home message. That is the take-home message, really the bottom line for this entire podcast. TMD Demystified. If you understand what I went over in the past 20 minutes, then you understand all aspects of TMD Demystified. It is that simple. And so I brought it together going back historically, because I think it's very important. And reading these papers, it was just amazing that they touched on things that we now take for granted and didn't know how close they were getting to the truth, like the position of the petrotympanic fissure, but the relationship of inflammation going through the petrotympanic fissure was not discussed. So there's certainly more to it that I've developed and understood as doing this research on this topic and going back historically. I'd like to speak on more aspects of it. Especially, I think we're going to see, I will produce in the future, not sure will it be next episode or not, but I will discuss now some things that we are doing here in Nashville, Tennessee, in this practice and with TMJ Services to investigate the use of orthotics in association with dentures, full dentures, for the patients who have no teeth, but still have TMD, TMJ problems. And there's no lack of those. The problem was not created by the lack of teeth or created by the dentures. The problem was created when they had teeth. More often than not, when they bruxed. Bruxing causes a huge portion of temporomandibular joint symptoms, far and above the number of patients that are created by functional malocclusions or direct trauma. Although direct trauma is definitely a cause. I had a great patient just yesterday who not only was a boxer for a decade or so, but was rode the bulls in rodeos and literally got his jaw jerked tremendously to the detriment of his teeth, cracking multiple molars, but ended up with TMD problems in my practice. A lot more to be said about this problem in the fully disclosure of TMD Demystified. With that being said, I look forward to the next time that I'm able to speak with you. If you'd like to learn how to treat temporomandibular joint non-surgically using a very simple device that does nothing more than take the load off the temporomandibular joint, like a set of crutches takes the load off a knee, by separating the posterior teeth according to protocol with a patented, FDA-cleared, independent university studied device. You can learn more at www.urbanictmj.com. You can register for our next in-person seminar, which July 26th here in Brentwood, Tennessee, Franklin, Tennessee. Whole day, 8-hour seminar with 6 CME credits. You can register for that seminar, or you can also actually take an online course and avoid the seminar, and a 3-hour online course with 3 hours of CME credit will get you licensed and trained to begin treating patients with this device. I look forward to the next time we speak. Until then, I am Tony Urbanic, and this is TMD Demystified.